Thank you, Dr. Mahendra. And so the opening batsman, my duty is to first take up a subject which is actually the basic subject in the foot and ankle. To diagnose the foot and ankle conditions, I think I cannot put less stress on examining the patient. So the process of diagnosis of a foot and ankle ailment is just like process which happens anywhere else. So of course, the first thing is history taking, followed by physical examination, and then the investigations which are X-ray, CT, MR, or other pertaining to foot. Well, all this process is ultimately trying to lead us to a final diagnosis of a problem. Since the subject is to focus more on physical examination, I will just touch upon a few points of the history taking, which are pain, swelling, and disability. That is what the patient comes to you with. And now, when the patient comes with these particular symptoms or the problems or complaints, we start thinking of various conditions. And so, according to that, if a patient has a chronic ankle pain, what comes to my mind? Probably it is a synovitis or an arthritis of the ankle, which is primary or secondary to some other phenomenon, or it could be a silent osteochondral lesion of talus, which has started giving symptoms. And it could be some kind of an impingement arthropathy. So that's what, when a patient comes with chronic ankle pain, should strike your mind. Similarly, a chronic hindfoot pain at the back of the heel, Achilles tendinosis or osteogonum. On the medial side or on the plantar aspect, a tarsal tunnel syndrome should come to your mind. And pain which is sometimes medial, sometimes lateral, but in the hindfoot itself, PTTD, posterior tibial tendon dysfunction. Similarly, subtalar arthritis or peroneal tendon subluxation or tear. So all these differential diagnoses should come to your mind just from the history. Similarly, chronic midfoot pain, if somebody is telling you, pointing you the pain in the midfoot region, it's the talonavicular arthritis, tarsal coalition, again PTTD, and some kind of neuromuscular foot condition which has been persisting and now become symptomatic. Lisfranc arthritis means something resulting from a neglected Lisfranc injury or molar waist syndrome or a stress fracture of navicular. So these are the conditions for chronic midfoot pain which should strike your mind. Similarly, for forefoot pain, you have to think of MTP arthritis, the bunion, the metatarsalgia, stress fractures, hammer and claw toes, Morton's neuroma. So all these differential diagnoses should come to your mind as soon as the history taking is completed. Chronic disability means patient may not have much pain, but quite disabled from ankle instability, repeated twisting, the neuromuscular foot with a deformed foot, the walking becomes very, very effortful. Similarly, residual CTV, vertical talus, or a diabetic foot with a wound, or Charcot arthropathy making the foot unstable with impending ulcer. So all these conditions come to your mind when a person is disabled but may not have that much of pain. So now we go on to the physical examination with this background in our mind that what we are looking for. And the physical examination starts from the moment patient is entering into my chamber, into the OPD where I'm sitting and examining the patient. So I observe his gait, as the patient is entering my place. And maybe I can make him walk a little bit more. And you're well aware from the general orthopedic sense that patient may have an antalgic gait, a hemiparetic gait, spastic or short limb, or a combination of various gaits. But as far as it comes to foot and ankle, then I'm observing the foot specifically. So you see this guy who's walking on toes. This is typical of gastrosoleus contracture or equinus. Similarly, if you walk this lady, she's practically walking on the lateral border of the foot on the left side, and which is due to the cavovarus foot. Similarly, a patient with a valgus heel and flat foot will be walking, putting more load on the medial part of the foot. I would say that if you are a beginner, or maybe even you can make it a routine to mark your surface anatomy on the foot. Certain salient points like medial malleolus, tibialis anterior tendon, the ankle joint line, the peroneus tertius, the lateral malleolus, the vertical axis of the heel, all these can be marked in the beginning so that when you are examining, it makes things easy for you. So first thing we do is now examination in a standing position. It is preferred that you have a high platform so that your eyes are at the same level as feet, and both feet should be parallel. The patella should be facing forward. So, and the limbs must be exposed right up to the knee joint. So when you do this, you observe the patient from all the sides, from back, from the side, from the front. So you can kind of move all around the patient, and you can see, start looking from the knees, whether the knees are well aligned or they have varus valgus deformity. Look at the calf, whether the calf is trophied or is it fine, whether the heel is aligned neutral or it is valgus or it is deviated to varus. Look into all these things. And then you observe from back about the swelling on the medial aspect or prominence of the medial aspect. Look at the first and fifth MTP joint. Look at the heel. Is everything making contact with the ground? That is what the foot is plantigrade or not. Similarly, look at the medial arch. Is it elevated like in cables, or is it depressed as in flat foot? Observe from back the so-called too many toes sign, which is characteristic of a midfoot abduction and collapse of the medial arch, as would happen in posterior tibial tendon disease, or maybe in developmental flat foot in the advanced stages. Now look from the front. Look at the toes. Look at, are the toes having a claw deformity? Is there a hallux valgus? Is there a crossover of the toes? So all these things have to be noted when you observe from the front. Next, you make the patient sit down. Preferably, make the patient sit down on your examination table. And I prefer to sit in the front on a chair and come close to the patient, hold the foot in my hand. So this makes patient very comfortable when you're doing the examination in sitting position. What are we doing first? First thing is inspection. We're inspecting the skin. We're inspecting for any swellings, any ulcers. We're not only seeing the dorsal skin, we're seeing the plantar skin, which may show you sometimes a trophic ulcer, as would happen in a spinal dysarthrism with the cavovarus foot. So all these lesions are to be noted. And then come to palpation. Before, before I
I think there's some
Yeah.
network.
Am I audible, right?
Yes, yes.
Yeah. Okay. So before I tell the patient, I start doing palpation at different points of the foot. I always ask the patient, where is the pain? Put your finger, put your one index finger at the point where you have maximum pain. Because then I know that I have to be gentle with the patient when I'm touching that point. And also my examination should revolve around that area. So, and it's a good practice to always follow a particular pattern, like examining clockwise for the left foot and anti-clockwise for the right foot. So how does it go? Well, it goes by examining the medial malleolus, the anteromedial gutter, the tibialis anterior tendon, and I have in my mind tenosynovitis. Then I'm looking at the interior ankle joint line. I'm palpating the tibiofiltubular syndesmosis, and then the lateral malleolus, and then my thumb moves to the sinus tarsi, and then I feel the peroneal tendons at the back of the lateral malleolus, and then I touch the calcaneal tuberosity, and then I come back to the posterior tibial tendon on the backside of medial malleolus, and I feel the posterior tibial tendon all along till the navicular tuberosity. Just so that completes a quick examination from the front, and then I start looking at the plantar aspect of the foot. The plantar tuberosity of calcaneum is felt, the plantar fascia is felt, and you palpate right up to the MTP joints. You feel for the callosities on the plantar aspect of the foot and note them. And then you start examining beyond the ankle, feeling all these joints one by one, your talonavicular joint, calcaneocuboid joint, navicular cuneiform, tarsometatarsal joints. Palpate each tarsometatarsal joint to elicit the tenderness. Palpate the MTP joints, the metatarsals, and the interphalangeal joints for any tenderness, for any other issues. Once your palpation is completed, we move on to the joint examination, starting from proximal going distally. That means in order of proximal to distal, you should check the movements of the ankle, subtalar, tarsal joints, TMT joints, and MTP, and then IP joints. If one foot is affected, you should always make it a habit to compare with the contralateral normal side the range of motion. Otherwise, from the knowledge of the amount of joint motions which normally should be present, you can always note whether a particular joint has a restricted movement or not, and whether these movements are restricted with pain or not. And then you make the patient lie prone. It's because you want to observe the calf, the Achilles, and the plantar aspect foot properly. It's always a good habit, always to make patient lie prone. And you can also record the subtalar joint motion and measure them with goniometer if there is an important finding in that, and you can record that reduction of movement at subtalar joint using a goniometer. This completes my joint motion, and then I proceed on to doing a neurovascular examination. And first I do the vascular examination, feeling the posterior tibial and dorsalis pedis arteries, followed by nail bed circulation, which is very important to detect any peripheral arterial disease in the early stages. Next, we go on to the neurological examination, and the sensory assessment is done using SEMS Wenston monofilament, using a 5.07 or 10 gram nylon monofilament. Similarly, using a tuning fork, which creates a 128 hertz, you can check it on the interphalangeal joints. An early loss of vibration sense is typically seen in diabetics, sensory neuropathy. And then if there is anything to suspect, like tibial nerve injury or tarsal tunnel syndrome, you can also perform the Tinel sign over the root of tibial nerve to diagnose your TTS. And then we proceed to the motor examination. Motor examination is done by checking the muscle strength. As a group, you can check extensors, plantar flexors, everters, and inverters. But if you have a condition where you are treating post-polio residual paralysis or a myelomeningocele or a Charcot-Marie-Tooth disease, where there is a selective loss of muscle power, and you're planning to do some kind of a tendon transfers, then it's a good practice to check every muscle individually and record the power of the muscle and make a chart about it. In foot and ankle, there are certain special tests for a specific disease or to reach at a diagnosis. and they are performed based on the relevance of a particular case. However, few important tests I'm going to list here, though it is not possible to list each and every test, but few important tests I'm going to show you. So first is a heel rise test. Make the patient raise the heel, both the heels, and ask him to repeat it 10 times. Not just 1 or 2 times, it should be repeated more than 5 times. So from this, we interpret whether there is integrity of the posterior tibial tendon and the ability to lift the heel. And then we also observe the subtalar motion, and we see whether the subtalar motion is present or is it absent. This double heel raise is followed by a single limb heel rise test. So here again, the one foot is lifted, and then the patient lifts the heel of the other foot, and again repeats it. So this is a more definitive test for checking the function of posterior tibial tendon, and a very important test to diagnose posterior tibial tendon disease. We are also observing again the inversion and the subtalar joint mobility during this. So here you see how we say that heel rise test is positive or negative. So if you see this patient, you are not observing the subtalar motion in this. And while we are performing the single heel rise test, it's unable to do that. So next we go to Thompson's test. Thompson's test is done for integrity of Achilles tendon. So if you see it on the right side, when I'm squeezing the gastrosoleus, there is a plantar flexion. But while I'm doing it on the affected side, squeezing is not producing any plantar flexion. So absence means that the test is positive for Achilles tear. Silver Scott test. Silver Scott test is to diagnose the contribution of gastrosoleus to the equinus contraction. So when the patient is examined with the knee fully extended and we are unable to dorsiflex, then the knee is flexed. Knee is flexed, and again we passively try to dorsiflex the foot. So ability to dorsiflex the knee in the flex position, but not so in the extended position, suggests that the gastrocnemius is contributing to this equinus contraction. Anterior draw test. See the dimpling which is happening by moving the whole hind foot anteriorly on the tibia by stabilizing the leg at that time. So this is a very important test to check the integrity of the lateral capsuloligamentous structures like your anterior talofibular ligament and calcaneofibular ligament. Squeeze test for the syndesmosis. So a chronic pain in the ankle pointing towards the syndesmotic area, you squeeze the fibula and the tibia to each other about 10 centimeter proximal to ankle joint, and patient has pain at the ankle joint line. So this is a test to know the syndesmosis integrity when the patient has ankle pain. The Lashman test for the turf toe, you hold the toe in your hand and move it dorsally and plantarwards to see the integrity of the plantar plate of the MTP joint. Coleman block test. Again, this is a test whenever patient has a varus deformity of the foot or the varus heel, then you make the patient stand on a wooden block with the medial side of the foot or the great toe hanging off the block. This test would tell us whether the hind foot varus is driven by the forefoot or primarily in the hind foot itself. Mulder clicks is a test performed by moving your metatarsals dorsally and plantarly. You glide them, and if there is a neuroma between the third and fourth, and sometimes in between fourth and fifth metatarsal MTP joints, then the patient will complain of pain, and you can also observe a kind of a cluck with your hand. Tarsal tunnel stress test, when there are uh, paresthesias or symptoms which suggest that, what you can do is you can dorsiflex the whole foot, you can invert the whole foot passively, and also passively dorsiflex all the toes. So in this position, you try to hold the foot for about 30 seconds, and just like a carpal tunnel of the hand. So you stress the tibial nerve in this situation and observe for paresthesias or tinglings, which makes this test positive if the symptoms appear. Well, the examination of foot is never complete unless you spend some time examining the footwear of the patient. Look at the wear, which will tell you if there is an abnormal loading on the medial side or the lateral side, or in a particular area of the foot. And also, always examine if the patient is using some kind of an insert or a brace. So just examine that and record certain important points which would make your examination complete. So I would summarize: you make a list of positive and negative findings. So weigh them against the differential diagnosis which you are making as you are proceeding through the history taking and the examination, and then you narrow down your provisional diagnosis to one provisional diagnosis or two, that is a short list of differential diagnosis. Maybe now you need the help of investigations like X-rays and CT and MRI to confirm your diagnosis, not only to confirm, but stage your disease, to classify your disease uh, stage, and then you can probably come on to a conclusion as to how you are going ahead in managing this patient. So that is what needs to be done by the time you complete your examination. You must have a plan in your mind. Thank you very much. This is all I had to say about physical examination.
Thank you, Kamal. Thank you very much.